Hi, my name is Abby Casterline, and I've been working with a patient this past semester who was admitted to the nursing home at Heartland Health Care Center on October 29th, 2013. This patient is wheelchair stricken. However, apart from walking, he is mostly self-sufficient. He stays in the nursing home at Heartland for short periods of time when his son is not able to take care of him at his home. Patient is 72 years old, Caucasian, and has been widowed for 2 years. He served in Vietnam for 18 years and has shot and broken his clavicle while serving. After Vietnam, he was an industrial engineer for his entire career until his onset of multiple sclerosis in the late 1980s or 1990s. He has 2 children. His daughter lives in Illinois, and he lives with his son here in Michigan. His wife passed away 2 years ago from unknown causes. His mother died from renal cell carcinoma in her 60s. His father died of a myocardial infarction at age 69 with no known prior heart disease. He had one brother who had bipolar disorder and committed suicide. The patient had vital signs of 140/82 for blood pressure, a pulse of 74 beats per minute, 13 respirations per minute, and I was unable to take his temperature. The patient's chief complaint and reason for being in a motorized wheelchair is his multiple sclerosis, for which he was diagnosed with in 1985. He has full range of motion in his arms, however, he has very limited movement from his waist down. Besides his inability to walk, his multiple sclerosis does not interfere with his daily activities. In fact, he is perhaps the most active patient at Heartland Nursing Home. He has no aggravating or alleviating factors for MS. He says if he has an abnormal problem, it comes on randomly. He takes all of his medicine consistently, which verifies his efforts to treat his diagnosis. His perception of the problem is quite good in that he wants to do as much as he possibly can. He doesn't let his multiple sclerosis stop him from doing what he wants to do. He expresses a very positive outlook on life. Patient says his PTSD is also a chief complaint, and this affects him significantly. If someone moves too fast, he will experience a brief moment of fright and shock that is very apparent. He takes fluoxetine for the PTSD, but refuses any MHC evaluation. Patient also suffers from venous insufficiency, hyperlipidemia, generalized anxiety disorder, depressive NEC disorder, and gets frequent urinary tract infections. Patient got an appendectomy as a child. He has multiple gunshot wounds to his right ankle and fractured his clavicle in Vietnam from a blast injury. He experienced loss of consciousness and received surgery to remove the bullets. Patient broke his hip 6 years ago and also broke 1 or 2 ribs from falling in the tub. Patient is on numerous medications for UTIs, hyperlipidemia, PTSD, multiple sclerosis, GAD, and also depressive disorder. He also takes some vitamin supplements. Patient quit smoking tobacco over 43 years ago and claims no illicit drug use. In regards to alcohol, patient claims to drink 1 beer at night occasionally. Patient exercises each morning with some physical therapy for legs and exercise of arms and hands. Patient has consistent rest and sleep pattern. He gets approximately 8 hours of sleep each night and will usually take a short nap each day after lunch. Patient has recently gained weight and says he is the heaviest he has ever been. He is now making an effort to decrease his carb intake, increase protein intake, and decrease the amount of fatty and sugary foods he consumes. Patient says he has a great relationship with his son and lives with him for most of the year. His daughter lives farther away, and it appears that he wishes he was closer with her. Both his parents have died of health issues, and his brother committed suicide, so these could be added stressors. Also, his PTSD is quite strong at times and says he notices that he reacts more strongly to sudden movements than he should. Patient did not tell me about his history with a pressure sore on his coccyx or history of UTIs. If he is embarrassed about either of these, that might be an added stressor as well. Also, he seems to still be struggling quite a bit with the death of his wife from 2 years ago. Since patient's chief complaint was multiple sclerosis and PTSD, I performed a musculoskeletal assessment along with a neurological assessment. Before performing a musculoskeletal assessment, I asked the patient the review of systems questions for the musculoskeletal assessment. Patient does not have any limitations in performing activities other than using his legs. His wheelchair allows him to do almost all activities, although he is not necessarily moving around as much as he would like to be due to the wheelchair. Patient does not have arthritis, and there's no history of it in his family. Patient has bilateral lower extremity edema from his knees all the way down to his toes. His joints do not feel warm and none of his joints are painful. Patient exercises once a day, every day, doing therapy exercises for his legs along with other more intense exercises for his arms. Patient's diet is healthy now, however, he says that it was not healthy recently. As previously stated, he has now decreased his carb intake, increased his protein intake, and decreased the number of fatty and sugary foods he consumes. Patient does not have osteoporosis. In the summer, patient tries to get outside at least a couple times a week and almost always does. His wife always encouraged him to go outside, so now he continues to do so, as would be her wish. He enjoys going out into the sun. He has broken bones, including his hip, clavicle, and 1 or 2 ribs. Next, I completed the musculoskeletal system assessment on the patient. I assessed his muscle mass and bone structure, and all was normal. I could not assess patient's gait. However, I have subjective information from the patient that his right leg is shorter than his left leg due to his hip surgery. His posture while in his wheelchair is normal. Patient does not have scoliosis. Patient had popping of his TMJ muscle, however, he had complete range of motion of the TMJ muscle. Patient had a little trouble laterally bending his neck, but could complete flexion, extension, and hyperextension of his neck with ease. Patient had complete range of motion in his shoulders, elbows, wrists, and fingers. I could not assess patient's range of motion in hips as he cannot stand. Patient had a slightly diminished range of motion while extending his knees in his wheelchair, but could mostly perform. Patient could not complete any inversion in his right ankle and also could only complete eversion slightly. Patient had trouble with all motions in left ankle as well. However, there was much less range of motion in the right ankle. With the exception of hyperextension, which I could not assess, patient had full range of motion in spine. Patient had a muscle strength of 5 out of 5 for deltoids, biceps, triceps, wrists, fingers, and hamstrings. Patient had a 4 out of 5 muscle strength for his left quadricep and a 3 out of 5 muscle strength for his right quadricep. Patient had a 4 out of 5 muscle strength for his left ankle and a 3 out of 5 muscle strength for his right ankle. I could not assess the muscle strength of the patient's hips. For all of these grades of muscle strength, a 5 out of 5 means that the patient met my pressure with strong resistance. A 4 out of 5 means that the patient had decreased strength. And a 3 out of 5 means that he could resist against gravity. Next, I completed a review of systems questionnaire for the neurological system assessment. Patient says his stress level is relatively low. He has blood pressure of 140/82, which is elevated. Patient has never had a stroke or seizure. He has had 1 back injury from trying to put a pipe in a long time ago. He has never been diagnosed with Lyme disease, meningitis, dementia, or Alzheimer's, and he has no family history of dementia or Alzheimer's. He does not have Huntington's disease, myasthenia gravis, or Parkinson's disease. He does have multiple sclerosis. Patient's vision is OD negative 2.75 and positive 0.5, and OS negative 2.25 and positive 1.25. He has some trouble with vision, but not when he was wearing his glasses. He sometimes experiences numbness and tingling in his arms and legs. He describes it as feeling like there are cold water drops on his skin. He says this feeling is not constant and he only experiences it at random times. Most of the questions for the mental status, motor function, sensory function, and reflexes I assessed during the actual neurological assessment. However, some of these questions were not included in the assessment, so I asked the patient them. The patient has no trouble with crosswords and actually really enjoys them. He has no trouble coming up with the words for them because he loves to read. He is not currently planning any trips with his family, but is looking forward to going back to living at his son's house. This told me that he is very much able to think about the future. Patient has been in a wheelchair for about 20 years now and is currently unable to walk. He does not feel dizzy with his eyes closed. Closing his eyes does not affect his ability to move his arms or legs how he would like. His motions are mostly smooth, however, at times his motions are exaggerated when someone makes a sudden movement or if there is a falling object. This is due to his PTSD. The patient's favorite smell is vanilla, and he can distinguish smell very well. His reflexes are, again, sometimes exaggerated due to his PTSD. However, other than that, he is in fact able to respond quickly and catch something falling before it hits the ground. His arm reflexes are better than his leg reflexes. The decline in his leg reflexes started coming after his diagnosis of multiple sclerosis. Next, I performed the neurological assessment on my patient. First, I assessed his mental status with the mini mental exam. Patient was alert and oriented times 3. Patient was able to repeat the 3 unrelated objects, which were boy, green, and dog. He was also able to correctly remember these objects when asked later on. Patient counted backwards in 7s from 100 correctly. Patient was able to name what a pencil and watch were and correctly repeated the phrase, no ifs, ands, or buts. The patient also correctly completed the 3-stage command with the paper. He wrote a complete sentence with meaning, and it was, the quick brown fox jumped over the lazy dog. He was able to copy the design so that the 2 shapes crossed over each other and each had 5 sides. His level of consciousness was alert. That completed the mini mental state exam and he received a perfect score of 30. Moving on to the rest of the neurological assessment, I was unable to assess the patient's general motor function or perform a Romberg test due to the patient's inability to walk. His upper and lower extremity fine motor function was completely normal in all tests. Patient's light touch, painful sensation, and vibratory sensation functions were normal for upper extremities. I was unable to assess these functions in the patient's lower extremities due to the socks he was wearing for his edema and the inability for the patient to remove or lift his pants. Patient correctly completed stereognosis with a pen, comb, and tissue paper. Although I was unable to assess for Babinski or ankle clonus in the patient, he told me that he has in fact tested positive for both Babinski and ankle clonus. In relation to the patient's multiple sclerosis, another assessment I could perform is a respiratory assessment. One article by Dr. Herbert Karpotkin called Respiratory Changes in Muscular Sclerosis highlighted on a study done by Fry et al. Although many authors have documented diminished respiratory function in those with advanced MS, this study by Fry et al. Found that even those with mild multiple sclerosis have a significant link to diminished respiratory function. My patient has MS, however, it was not extremely advanced as it was only apparent in his legs, and he was even able to move his legs a small amount. Even so, because of the study done by Fry et al., an assessment that would be important to perform on my patient would be a respiratory assessment. According to Pasella, Hruska, and Delahanty, in their study of the physical health consequences of PTSD and PTSD symptoms, PTSD may be particularly related to GI distress. The research indicates positive relationships between PTSD and GI health problems, including irritable bowel syndrome, ulcers, vomiting, and constipation/diarrhea. All of these were across varied samples and settings. Due to these findings, another assessment I could perform on the patient would be an abdominal assessment, since the patient does suffer from PTSD. Thank you.